Okay, we're going to start talking about the hip by talking about the osteology. So we're going to talk about all the bony features of the hip, which ones are palpable on a human being, and we are going to practice palpating those in lab. And some of them, of course, are not palpable on a human being. And so in lab, we will find those on a bony model. So starting with the hip, we are going to have the learning objectives of identifying the bony landmarks of the hip and their anatomical position to one another. So if I hand you a disarticulated pelvis, you should be able to identify all of the bony landmarks on it. If I hand you a lab partner, you should be able to palpate all the palpable bony landmarks on there. You'll do that in lab. In the Canvas module, there is a separate set of learning objectives for the lab, and really it's very hands-on. You're going to learn to palpate all these structures. So we start with the lower extremity for a lot of reasons. Even though it's towards the end of the book, we start with the lower extremity because most of the structures on the lower extremity are easier to palpate than on the upper extremity and the spine. And the innervation is relatively simple, and we're talking about a big group of bones. So starting with the lower extremity, you'll get used to the idea of palpation and how things feel, and then we'll move into the more difficult ones towards the end of the quarter. The other two osteological learning objectives are, we're going to discuss some features of the femur called the angle of inclination and the angle of torsion, and describe how they affect the hip and the knee. Number 3 is describing coxa vara and coxa valga and their effects on the femur. And actually, coxa vara and coxa valga are effects of an angle of inclination that's out of the norm, or an angle of torsion that's out of the norm. So we will talk about that in this chapter, and we will also talk about it in the knee chapter, because what happens at the hip affects the knee. So the most proximal bone in the hip is the os coxa, or innominate bone is the other name for it. And it's a fusion of 3 bones, the ilium, the ischium, and the pubis. They're irregularly shaped, all 3 of them, and they start out connected by cartilage when you're a baby, and they're fused fully into bone by adulthood. The fused ilium, ischium, and pubis form the acetabulum, which is the cup shaped articulation with the head of the femur. Okay, so there's a little bit of ischium, a little bit of ilium, and a little bit of pubis in the acetabulum. The femur is the longest bone in our lower extremity, and that is the other part of the hip joint. Okay, and we'll talk about bony landmarks on all of them. So the ilium is the superior winged portion of the innominate bone. So it's this big curved portion. The iliac crest is the long ridge of bone that marks the superior ilium. So this is very palpable on human beings. You should be able to palpate the iliac crest. We often palpate the iliac crest because we're looking at whether or not your hips are level. We're looking for symmetry in the pelvis. And so not only is it easily palpable, it's often palpated. So the superior border of the iliac crest is the anterior superior iliac spine, and it's abbreviated ASIS. It's the anterior tip of that iliac crest. Just inferior to that is the anterior inferior iliac spine, the AIIS. It's a proximal attachment for the rectus femoris muscle, which is one of our major hip flexors. And the ASIS is very palpable. The AIIS, you can palpate it on most people, but it's more difficult because it's under a few muscle bellies. And so we often use the ASIS as a landmark for different measurements because it is more easily palpable on most people. The posterior ilium has the posterior portion of the iliac spine is the posterior superior iliac spine. So if you run your finger along the iliac crest from the most anterior to the most posterior, you're going from the anterior superior iliac spine to the posterior superior iliac spine. The PSIS is palpable on most people. The posterior inferior iliac spine is a small bony prominence inferior to the PSIS, and it marks the superior tip of the greater sciatic notch. And it's palpable, but it is under a lot of ligaments and some muscle bellies, and so it is a little bit more difficult to palpate than the PSIS. So the greater sciatic notch is the semicircular space between the PIIS and the ischial spine, and it provides space for the sciatic nerve to exit the pelvis. So the sciatic nerve is huge. It's like the thickness of your thumb. So it needs room to exit the pelvis so it can get down and innervate the lower extremity. When we start talking about innervation, you'll see that the sciatic nerve innervates a large portion of the leg. The iliac fossa is the smooth concave anterior surface of the ilium. It provides proximal attachment of the iliacus muscle, which is part of one of our major hip flexors. The ilium articulates with the sacrum, forming the sacroiliac joints, and that joins the entirety of the pelvis. I have just one half of it here, so I don't have a sacrum, and I don't have the other half of the pelvis. In the mini skeleton lecture, I have the whole thing. So the ischium is the posterior inferior aspect of the innominate. So if you look at, I'm going to draw on my picture a little bit. So this superior part is the ilium. The posterior inferior part is the ischium. And this part here is considered the ischial ramus. Ramus means an arm. The anterior inferior part is the pubis, and it has two rami, two arms. It has the inferior ramus and the superior ramus. So the ischium has one ramus and the pubis has two rami. So the ischial spine is the posterior projection marking the inferior aspect of the greater sciatic notch. So this is the greater sciatic notch. This is the posterior inferior iliac spine, and this is the ischial spine right there. The ischial tuberosity is this bumpy inferior posterior aspect of the ischium, and it serves as a proximal attachment for 3 of the hamstring muscles. So it's a big bony prominence at the bottom of the pelvis, and it's rough. Anytime when you have a rough area on a bone, something articulates or attaches there. So bone responds to the pressures that we put on it. So muscles tugging on bone are going to create bony prominences. And so most of our bony prominences are muscle attachments. So the ischial tuberosity, sometimes people call it the sit bones because you sit on it. And it can be a point of pressure if you have to sit all the time. And so that is an area that we're certainly concerned with. The ischial tuberosity is very palpable. The ischial spine is not palpable usually on a human being. So there is a ligament that goes from the PIIS, or a couple of ligaments that close up the greater sciatic notch and turn it into the sciatic foramen. A foramen is a hole. You need a hole for structures to go through. And so the ligaments close up that notch and make it into a foramen. Okay, we'll clear those drawings. So people sit on their ischial tuberosities so they can be often the site of pressure ulcers occurring in persons who lack normal sensation or lack the ability to relieve pressure by themselves. So a lot of times someone in that situation will need a tilt in space wheelchair for pressure relief. That is a good reason for needing a tilt in space wheelchair. The people who have upper extremity strength can often do pressure relief with their arms by doing wheelchair push-ups. And that's very important for maintaining circulation in that area. The ischial ramus extends anteriorly from the ischial tuberosity to join with the inferior pubic ramus. So when we look at, this is the posterior inferior iliac spine, this is the greater sciatic notch, this is the ischial spine, these are the ischial tuberosities, or this is one of them, and then this is the ischial ramus. So it projects anteriorly and it joins with the inferior pubic ramus. The pubis is composed of two rami, the superior pubic ramus and the inferior pubic ramus. So when we look on here, this is two halves of the pelvis joined together. So we have the superior pubic ramus here and the inferior pubic ramus here. That's the right hand one. This is the left superior pubic ramus, and this is the left inferior pubic ramus. Okay, so the two rami coalesce anteriorly. Don't you like that word? And they form the pubic crest. The pubic symphysis is a junction between the pubic crests, and that completes the anterior ring of the pelvis. So the pubic symphysis is a cushioning joint, and there is a little bit of motion in it, but not a lot. It's structural. The obturator foramen is the large circular opening that's formed by the pubic rami and the ischial ramus. So we know that a foramen is a hole and something's going to go through it. So there's a membrane that covers the obturator foramen. It's called the obturator membrane, but the obturator nerve runs through that membrane. The obturator membrane also serves as a proximal attachment for the obturator internus, which is one of the deep hip rotators, and the obturator externus, which is another one of the deep hip rotators, which we'll talk about in the muscle chapter. So if you want to see these on the mini skeleton, there's a separate lecture that includes them on the mini skeleton. The acetabulum is a cup-shaped structure that encloses the head of the femur, and it's formed by the combination of all three pelvic bones. So if you look at the acetabulum, you can almost divide it into thirds. So this is the ischium third, this is the ilium third, and this is the pubic third. Oh, sorry. This is the ischium, this is the ilium, and this is the pubis. So all three of them contribute to forming that cup. The lunate surface is the horseshoe surface superiorly in the acetabulum, and that is actually the weight-bearing surface that comes in contact with the femoral head. So the pelvis sitting right on the femur, that's the surface that it articulates. It's heavily lined with articular cartilage for gliding and for shock absorption. The acetabular fossa is a deep depression within the floor of the acetabulum, and it provides attachments for some of the ligaments, which we'll talk about in some of the later lectures. So the femur, so obviously you can't palpate the acetabulum. So of the palpable structures in the hip, you can palpate the iliac crest, you can palpate the ASIS and the PSIS. Sometimes you can palpate the AIIS and the PIIS. You cannot palpate the greater sciatic notch. You cannot really palpate the ischial spine, even though you can sort of figure out where it is. You can definitely palpate the ischial tuberosity. You can palpate the pubic crest. People don't like it, but you can. So, you know, getting to know your classmates, eventually you're going to be palpating their pubis, but my advice on that is start high and stay high. So you can palpate the pubic crest, and a lot of times it's important for assessing pelvic symmetry. You can't palpate the obturator foramen, that's really difficult, and you cannot palpate the acetabulum. So with regard to the femur, The proximal femur, which articulates with the hip, is composed of the head, the neck, and the shaft of the femur. So the head of the femur, get my little pencil here, is the ball of the ball and socket joint. It contains a depression right at the end that's called the fovea, which accepts the ligamentum teres. And we'll talk about the ligamentum teres in the hip stability lecture. It attaches the head of the femur. So you can imagine the little elastic that I have on my model here as the ligamentum teres, attaching the head of the femur to the acetabulum. The femoral neck connects the head to the shaft. So this part right here is the femoral neck. A lot of hip fractures occur at the femoral neck. Interesting. It is bordered superior laterally by the greater trochanter. So the greater trochanter is a huge attachment site for a lot of muscles. So that it's a big bony prominence, and there are a lot of muscles attached to it. So anytime you have a big bony prominence, chances are good that there are going to be a lot of things attached to it. So the greater trochanter extends laterally from the near junction of the femoral neck and shaft. In terms of being palpable, the head of the femur, not palpable. It's inside the acetabulum. The neck of the femur, also not palpable. The greater trochanter, yes, we will and can palpate that greater trochanter. It's a landmark for goniometry, and it is also a landmark for finding different muscles. So we're definitely going to palpate the greater trochanter. The lesser trochanter is a sharp posterior medial projection of bone. It's on the medial side of the femur. So the greater trochanter is on the lateral side, the lesser trochanter is on the medial side. It's the distal attachment for the iliopsoas muscle. So if it weren't right next to the greater trochanter, we'd say, wow, that thing's huge, but it's right next to something that's way bigger and it makes it look small. But that is a big bony attachment for a big muscle to attach to. It is palpable, although it's under a lot of muscle, so it's not as easily palpable as the greater trochanter. The intertrochanteric crest, that is the ridge of bone that connects the posterior aspect of the greater and lesser trochanters. So on the posterior side of the bone, we have this big bony ridge, and that is the intertrochanteric crest. Anytime you hear a crest, that is a big bony ridge, like the iliac crest, the intertrochanteric crest. It's a big bony ridge that attaches two structures, basically. The intertrochanteric line courses anteriorly between the greater and lesser trochanters, and it marks the distal attachment for the anterior capsule of the hip. So the intertrochanteric line is not as pronounced as the crest. The crest is huge, craggy crest. The line is a smaller, yet still noticeable on a bony model line. The intertrochanteric or the trochanteric fossa is a small pit on the posterior medial greater trochanter, and a lot of the hip external rotators attach on it or near it. So a little pit to attach those muscles to. So you cannot palpate the intertrochanteric crest, intertrochanteric line, or the trochanteric fossa. There's just too much muscle on there to be able to palpate those things individually. So that's one of the things, one of the ways to tell if something's palpable or not. Are there lots of muscles or structures on top of it, or is it inside of another structure or very interior to the body? The linea aspera is a line of slightly raised bone that courses along the posterior side of the femur. It is the distal attachment for many of the adductor muscles and the proximal attachment for the vastus lateralis and vastus medialis, which are two of the quadricep muscles. So the linea aspera cannot be palpated because there's lots of muscle on top of it. It's deep to the hamstrings and it's the adductors are attached to it, and the vastus medialis and lateralis are attached to it. So you can't find that with your fingers. There's too much muscle over it. However, on a bony model, you can't not find it. It's really obvious. The pectineal line is a small crest of bone running from the lesser trochanter to the superior aspect of the linea aspera. It sort of forms a little Y with another structure, which we'll talk about in a second, at the top of the linea aspera. So the pectineal line, not surprisingly, is the distal attachment for the pectineus muscle. So a lot of times, people who named anatomy weren't trying to be obscure about it. They were trying to be very obvious. The gluteal tuberosity arises from the superior lateral portion of the linea aspera and serves as a distal attachment for the gluteus maximus. So it forms the other leg of the Y with the pectineal line at the top of the linea aspera. Once we start attaching muscles, we're going to head down to the distal portion of the femur, and we are going to end up on the adductor tubercle. So the adductor tubercle is a raised portion of bone located just proximal to the medial epicondyle. It's right there, very palpable. It marks the distal attachment of the adductor magnus muscle. Adductor magnus is a huge muscle that spans a wide range of area in your thigh. It really kind of fills in all that space in between your femur and your midline, basically. So, and it performs a lot of great functions too, which we'll talk about in the muscle chapter. So the adductor tubercle is very palpable on people's knees, and we will find out how to palpate it in lab. So let me delete my scribbles. So when we start looking at the femur, we see that there are some angles in the femur because the head and neck of the femur are at an angle to the shaft of the femur. That frontal plane angle created between the femoral neck and the shaft of the femur, it has the function of directing the distal end of the femur down towards the tibia, where it articulates at the knee. The average, normal, optimal, whatever you want to call it, measurement for the angle of inclination is about 125 degrees. So that 125 degrees directs, so if you had it, the femur straight up, it wouldn't meet the tibia at the knee. So it directs it medially, so it meets the tibia at the knee. It also determines how the head of the femur is going to articulate with the acetabulum. So if you had at our normal 125 degree angle of inclination, that maintains our good alignment. If we had less inclination, it would direct the femur laterally, and we would end up with what's called coxa vara. If we have more, we end up with coxa valga. So we'll look at some pictures of the whole lower extremity structure and see what the upshot of that is. So if you have a different angle of inclination, the femur has to change in order to be articulated with the acetabulum. So if you had a decreased angle of inclination, you would have to, a decreased angle of inclination, the distal end of the femur would have to move more medially in order for the head of the femur to rise up enough to articulate properly with the acetabulum, and you would end up knock-kneed, basically, or genu valgum is what they call it. Coxa vara and genu valga go together. If you have a greater angle of inclination, the distal end of the femur would have to move laterally in order to articulate, and you would end up with bow legs or coxa valga. So we'll look at the knee and the hip together and see how they relate. So deviations from normal angle of inclination can occur from abnormal development in early childhood or trauma in early childhood. So coxa valga is an angle of inclination that is significantly greater than 125 degrees. So in the previous slide, it was showing it at 140 degrees. So whatever childhood trauma or developmental issue caused that, it's a greater angle of inclination than 125 degrees. Coxa vara is an angle of inclination that is significantly less than 125 degrees. So store that little nut away in your brain, and then when we talk about the knee structures, we will put these all together. The angle of torsion, so the femur has a natural twist along its axis. The femoral neck normally projects upward, if we're looking at it from the end here, about 15 degrees. It's often referred to as normal anteversion. So this would be flat, this would be anteverted, and retroverted would be the opposite way. It's associated with optimal alignment between the femoral head and the acetabulum. So excessive anteversion can lead to anterior instability of the hip. So if the hip were excessively, the angle of torsion were excessively anteverted, the anterior part of the hip would be more likely to dislocate. Okay, so that's just instability in the hip. Usually, you can only detect these by radiographic analysis, so X-rays. You can't palpate, you can't look at someone and tell whether they have an increased angle of inclination or an increased angle of torsion. It does result in some things that are observable, like a toed-in effect if you have excessive anteversion, or a toed-out effect if you have excessive retroversion. But just because someone is toed in or toed out doesn't mean the problem is at the hip. It means the problem could be at the hip. You could also have problems in the tibia and problems at the knee to cause that same effect. So some of the results of an out of range angle of inclination or angle of torsion can be observed, but you can't conclude that that's what's causing it unless you have that X-ray to confirm that. Can we do anything about that in physical therapy? Can we change people's bones? Unlikely. Can we work on stabilizing their muscles to stabilize their hip? Absolutely.